giving this talk on behalf of Professor Anne Duggan and Mr Ian Skinner, who headed up our Clinical Care Standard topic working group on the colonoscopy clinical care standard. And it's always good to start a presentation with a bit of a light joke or an anecdote to sort of get people in a bit of good mood. And I thought with colonoscopy there'd probably be a pretty rich seam of humour that I could kind of get into, but then my mind started to go to some pretty dark places, so I decided to leave it alone. I might let you jump in there, Craig, later if you feel like it. So why did we do this colonoscopy clinical care standard, and why are we interested in colonoscopy? Well, colonoscopy, and another reason why I didn't want to tell a joke as well, is that colonoscopy is actually not a kind of laughing matter. It's not a benign procedure. It's not the worst procedure you'll ever have, but it's also not the least unpleasant. So it involves a couple of days of what's euphemistically called bowel preparation, diarrhoea basically for a couple of days off work before, maybe after to recover, sedation during the procedure, which also has some risks, and then the procedure itself, which I won't go into. And Australians undertake or have more than 800,000 of those procedures are done in Australia every year, which is roughly one for every 32 Australian of any age. So it's quite a significant number of colonoscopies that are being done. And the rates are increasing. Sorry, this slide is a little bit hard to see, but the red is basically colonoscopies where there has been an excision or something removed, and the blue is colonoscopies without excisions. So most colonoscopies are done for bowel cancer in the context of bowel cancer, and you'll probably be familiar with bowel cancer screening, where it's usual practice to have a fecal occult blood test first, and if that's positive, then you'll go on to have a colonoscopy. Colonoscopy, if it identifies a polyp or a lesion, it'll be removed, and then depending on what that says, there are very clear guidelines for how often you should then be screened or not, according to a whole bunch of different factors. And those recommendations for screening intervals are clearly described in evidence-based guidelines from the Cancer Council. And the whole process is really pivotal to reducing bowel cancer in Australia, and we have a very good national bowel cancer screening program here. So it's an important procedure. But we do know there's variation, so we know there's up to 30 times variation in the number of procedures that are undertaken between the highest rate area in Australia and the lowest rate area. And that's important because it also ties into the equity and appropriateness of care. If some people are having the procedure and they don't really need it, that means that it's not available to other people who perhaps do need it more. And there is a difference between, rates in Aboriginal and Torres Strait Islander people and across different geographic areas and socioeconomically as well. So it's a good topic. And the role of the Commission is to promote appropriate care. You've probably heard of us more in relation to the Atlas or the National Safety and Quality Health Service standards, which are the accreditation standards. So all acute health services in Australia have to undergo accreditation, and they have to be accredited to the national standards. And this year is the first year of the second version of the national standards, and there's a couple of changes in the standards this year. One of them is that reference healthcare variation more closely. So we're asking health service to actually monitor their variation and to address it at a local level. And the other thing is that we're asking people to look at the clinical care standards as one way of implementing evidence-based care. And for colonoscopy, that's actually been made a mandatory requirement that they do comply with the colonoscopy clinical care standard, which supports the use of evidence-based guidelines and a whole bunch of other things to do with providing a high-quality colonoscopy, which I won't go into now, but you can read more about them on our website. And I should have also said that there are some choosing wisely recommendations around colonoscopy as well. So it's obviously an important topic. Both RACGP have got a statement around use of FOBT for screening rather than screening colonoscopy straight up. And the Gastroenterology Society also supports the use of the NHMRC guidelines for screening intervals. So that's really all I wanted to say. You can find out more on our website. I guess I just wanted to reiterate that this is a little bit different from the really great work we've been hearing about today, but it's more of a system intervention and thinking about how that can tie into the other work and be a lever for reducing inappropriate variation. Thank you.